Oh, fantastic. Well, thank you so much, Dr. Hani, for our invitation. As you know, I'm not a congenital cardiac surgeon, but sometimes we have faced these problems in which aortic dissection, a very life-threatening disease, coming together with pregnancy, and then we have to work in a multidisciplinary team with cardiologists, pediatrics, neonatologists, perfusionists, anesthesiologists, and cardiac surgery in order to address this big important disease. It's very, we know this entity is not very common. Maybe all your life in surgical career, congenital cardiac surgery, never seen this kind of patient. The incidence is between 0.1 to 0.4%. So regardless, it's very, very rare to see this patient. The situation sometimes is extremely difficult to decision in order to do the safety for both the mother and the baby. So I like to start the presentation when one case is happening in the Cleveland Clinic. As you can see, is a 40 years old female with 36 weeks of pregnant with sudden chest pain, severe chest pain. The patient went to the emergency department, found to have a type A aortic dissection, meaning from the aortic root all the way arch, descending and, until the femoral vessels, with very difficult to manage the chest pain. So because of the kid was 36 week, they were able to emergency cesarean section and transfer to the Cleveland Clinic to take care of the aortic dissection. As you can see, this is a preoperative TEE. Interesting though, so we confirmed with the diagnosis of VVK type 1 or type A dissection. Interesting to see in the echocardiogram, you can see the aortic valve completely prolapsed with a severe aortic regurgitation. And then the ascending aorta is a big ascending aorta with the flap completely towards the aortic valve. This is the intimal flap. This is a false lumen. This is a through lumen. The commissure lost completely attachment. That's why the leaflet's coming down and creates severe aortic regurgitation. Also, the patient has a functional severe tricuspid regurgitation, maybe related for the overloaded, the thing that we see in patient with pregnancy, with a hyperdynamic state, and also annular dilatation of the tricuspid valve. The course of the operation, usually in this kind of patient, we have to do a circulatory arrest and dehyperthermic circulatory arrest in order to not just only replacement or repair the aortic valve, but also replace all the ascending arch and descending aorta. So the patient underwent a cardiopulmonary bypass through the right axillary artery. We usually find more than 80 to 90% of the patient when they have the aortic dissection, the subclavian artery or the axillary artery are not compromised, so we can access an antegrade flow. We just put the site for 8 millimeters Dacron graft or 6 millimeters, depends on the artery size or the body area. But usually 8 millimeters give us a flow at least 3 to 5 liters per minute. In this particular case, we did deep hyperthermic circulatory arrest and right retrocerebral perfusion, to protect the brain. And then we did the ME-arch replacement, and with deployment of the frozen elephant trunk is a stent graft in the descending aorta to reestablish the through lumen and try to obliterate or occlude the false lumen. Aortic root reconstruction in this patient, because they're a very young patient, usually we try to preserve the own valve because the valve itself, it doesn't have any disease most of the time. Usually has, as I said before, lost completely attachment on 1 or 2 commissure at the level of the dissection. So we try to resuspend the valve and preserve the valve. That's the thing we did in this particular patient. Also tricuspid regurgitation, because it was a functional tricuspid regurgitation, mainly were volume overloaded. We did bicuspidization of technique we call the K technique in order to increase the coaptation between the posterior and septal leaflet. That was the treatment. The post cardiopulmonary bypass TEE preserve function. We protect the heart very well, and then has a trivial AI and trivial mitral tricuspid regurgitation. The patient was discharged at 10 days with a healthy void. This is a CT scan, and you can see here. Let me show you. This is go back a little bit. You can see all the neck vessels were not dissected. I don't know if you can see. Okay. Then the stent graft going all the way. And then Infradiaphragmatic, we can see the double lumen again, but the through lumen, all the vessels coming from the SMA and renal arteries coming from the through lumen, good perfusion. And then if you can see in the CT, in this 3D reconstruction CT scan, you have see all the graph of the ascending aorta ME arch, and then the frozen elephant trunk with completely normal position of the graph without having false lumen at the level of the thoracic aorta, completely obliterated. So the through lumen, all the blood going to the through lumen to the descending aorta. That's very, very important for us to get a really good control. Can you see? I think I need to close that. Can you see the next one? Okay, great. As I said before, it's a rare occurrence, account to 0.1 or 0.4 of all the aortic dissection. Pregnancy alone is independent risk of the aortic dissection. You know, it's during pregnancy, there's increased heart rate, stroke volume, cardiac output, and also left ventricular wall mass and end diastolic dimension increases circulatory volume. Plus effect of the hormones. You know, the hormones like estrogen and progesterone has an impact in terms of fragmentation of the reticulum fibers, diminishes the amount of acid mucopolysaccharides and create favorable loss on the corrugate of elastic fibers. So basically, the aorta became dilated, and then it create prone to more fraction of the intima and create the aortic dissection. This kind of situation occurs mostly in the third trimester or early postpartum. Consoling, this is very important. We have to preconcepting genetic testing and imaging in women with family history of aortic dissection, connective tissue like a Marfan is very important to see. We check with echocardiogram. We say that a patient with the aortic root, they mention more less than 4 centimeters, we can control during echocardiogram. But if a patient has preconceptive testing has more than 4 centimeters, we really provide the counsel of surgery prior to pregnancy, because this scenario can be a tremendous difficult for the patient to handle a dissection during pregnancy. So patient with more than 4 centimeters, we usually offer surgery like a Tyron David procedures, like a remodeling process of removal of the aortic of the ascending aorta, root aortic dilatation, and preserve the aortic valve. That's very important for the patient. Sometimes we can offer homograft, but usually we try to preserve the patient own valve. For sure, a typical multidisciplinary decision making prior to conception, for sure. This is a genetic disorder that you can have a possibility to see in this patient. Most of the time, Marfan syndrome is the most predominant of the connective tissue disorder. If you can see all the common clinical features and congenital defects, then we have a Lowen-Dietz syndrome, Erdmann-Lano syndrome, and Turner syndrome. But most of the patients come with Marfan syndrome that have skeletal features, ectopic lens, and the genetic and diagnostic tests, as you can see in the slide. Acute consideration, the mother health should provide over the fetal concerns. We usually think about first in the mom list when you have a baby less than 28 age of gestation. So going to cardiopulmonary bypass as circulatory arrest is difficult to anticipate advanced impaired placenta perfusion. Hypothermia usually decrease the flow to the placenta, increase the bradycardia, and also could be hypoxic events. So going to the cardiosurgery, cardiopulmonary bypass, circulatory arrest, and gestation age of 26, 24 is really difficult to maintain a life of the fetal. That's why you have to get a multidisciplinary team approach, to discuss, and then discuss very, very important with the patient wishes in order to move forward with the surgery. So important. So this is a multidisciplinary decision: cardiac surgeon, obstetrician, pediatrician, clinical care, and anesthesia and perfusion all together have to have a decision to offer to the patient and the family. Management strategy, multifactorial hemodynamic status, aortic dissection characteristics, gestation else, and patient wishes. We usually do guidelines prior 24 or 28 weeks as a gestation, urgent surgery with fetal monitoring. After 28 weeks, we suggest to urgent C-section followed by aortic repair. When we have a type B dissection, we usually manage medically unless the open or endovascular surgery is mandated by valve perfusion or rupture of the aorta. But most of the time with the beta blockers and manage, control the blood pressure, this is a monitored by echocardiogram and sometimes CT scan. We can control the patient over time to get the timing for C-section and repair. I think in conclusion, pregnancy is an independent risk factor for aortic dissection. Preconception counseling is a prophylactic surgery can avoid morbidity and mortality in aortic dissection in pregnancy. Very, very important to make a decision when the patient has a aortic root enlargement with a congenital Marfan problems. So that's a very, very important. Also, another important thing that we always need to find out if the patient has an aortic valve, bicuspid aortic valve. That could be another possibility to have this kind of dissection because loss of the elastic properties of the aorta and create more possibility of rupture on dissection. So aortic dissection pregnancy is a complex scenario requiring timely multidisciplinary decision making in order to get a successfully resolved on this patient. Very difficult situations. And then that's it. Thank you so much.